Hello, everyone, and welcome to this edition of EWMA 2020. And we all know that it moved from London to virtual, so we are now on a computer and trying to learn from each other. The title of my presentation is Proposal for a Free-Level Revascularization Strategy in Critical Limb Ischemia. Is it possible to revascularize everybody everywhere? And immediately came to my mind that I had many questions about the word everywhere. What does it mean? Does it mean everywhere in the leg, or even some procedure can be more challenging with the passage of the wire through, for example, the foot arch, and recanalization can be difficult due to many different reasons? Does it mean everywhere in every center where we should have, for example, good podiatry and good service for the post-procedural checkup and take care of the wounds? Or should we mean everywhere, like everywhere in the world? So let me try to start from everywhere in the leg. So we all know that there are different centers, and I try to divide them in three different levels. Level one is the basic vascular center, where we can be able to do any kind of very sort of simple procedure like this one, where there was an SFA occlusion at the level of the distal segment, very short, very focal, and actually the vessels distally were fine. You can see two vessels run off down to the foot, and you can see here there's a good presence of foot arch with good revascularization of the toes. You don't see any particular blush in the angio, so this is a good sign, and we need to try to improve the situation. You can see here now my catheter and my Y going very easily through this SFA occlusion. And after that, this was dilated just with a 5mm balloon. The result was not optimal, but definitely acceptable. And you can see how the foot improved so much with a nice blush at the level of the fourth and the fifth toe. I want to show you another simple case. Doesn't look maybe very simple, but I want to show you why it is. It's a typical diabetic patient. You see that the popliteal and SFA are fine, but that there's no named vessel going down to the foot, where just the recanalization of the anterior tibial artery and posterior tibial artery is done by branches of unoccluded peroneal. So you can see that when I went into the anterior tibial artery and I injected, I could see something that I was not able to see before. So the injection into the artery specifically showed me there are different spots of very tight stenosis, but actually there's no occlusion. The vessel is patent almost all the way down. And you can see my wire moving very easily into this vessel, taking almost no time to revascularize. You can see how smoothly it goes through this occlusion down into the foot, where I was able then to inject contrast and show that the dorsalis pedis and the distal anterior tibial artery were very healthy. So after a 3mm balloon angioplasty, and we always have to remember that the balloons are sometimes undersized compared to the size of the vessels. So 3mm angioplasty in a man is always, the right choice, if not even more. And after the PTA, you can see a complete different blush already at the level of the tissue loss on the lateral side of the foot, like here. But I was not enough, and I saw that also the peroneal was giving good branches to the posterior tibial artery, and I decided to, of course, try how easy was to cross this very short occlusion, and you can see the wire went through in no time. So very easy, and I checked I was in the right vessel, of course, and after 2.5mm angioplasty for this vessel, I achieved a very good result. You can see how I using a long balloon at the beginning and a shorter one to have more radial force for more focal stenosis. As I said, you can see now a very good result with two vessels running down to the foot, and you can see here how the ulcer at the level of the lateral aspect of the foot has a very nice blush, which means very good revascularization. You can see here, of course, the foot before the revascularization and the foot after. So very good result, where the ischemia was making the healing process not possible. So you can see now that not only for simple cases, but you can also try to do something more difficult, and will be between the level 1 and level 2 center, and I will show you why. This patient had an osteomyelitis and necrosis of the first tip of the toe. Of course, he had very multiple, as usual, factors, risk factors like diabetes and like dialysis, and this was classified with a Wi-Fi classification, which takes care of the wound, of the infection and ischemia, as a stage 4, which means it's high risk for amputation, but also high risk of success if correctly revascularized. You can see how the anterior tibial artery presented a very focal stenosis, which was treated by a 3 mm balloon, and this permitted the flow to flow in a better way. And if you look at the foot, it looks like it's quite fine. There are not many branches going directly to the first toe, and in particular, I want to show you this kind of stenosis, which were left untreated at the level of the distal dorsalis pedis and metatarsal arteries. You can see how the artery, was better on the angio, but the foot after amputation didn't heal, and it went even worse and worse and worse till this point. So this is point where the no level 1 center can deal with. We need to transfer at least now or even before, because it was already too late, the patient to a level 2, the advanced vascular center, where people know in more specific what to do. For example, in this case, you can see how the artery completely recoiled, and the IVUS is showing that the diameter of the artery is not 3, but is a bit more. So essentially, when I stented this artery, I use a 3.5 mm stent, which of course gives you a better result in terms of flow. But it's not just this case, it's not just this example, it's literature which shows that there's a level 1A evidence, and there are very few level 1A evidence in medicine, in this kind of vascular medicine, which supports the use of infrapopliteal drug-eluting stents to have better results. So, and also at the level of the very distal vessels, I wanted to recanalize this very tight stenosis and occlusion with my little wire 0.14 inches, and I dilated everything with a 2.5, 2 mm balloon, and a 1.5 at the level of the metatarsal artery, which was occluded very distal. So essentially, the post-PTA run shows a far better flow with a little bit of blush, and you can see here, even in the comparison between the first one and the second angio before and after the revascularization at the level of the distal level, how the flow is quicker, and also the blush at the level of the first metatarsal amputation is visible on the post pedal artery angioplasty. Pedal artery angioplasty, which is also very important, not just for this case, but also from the literature. For example, this study, which is called the Rendezvous Registry, is showing that people who are going for pedal artery angioplasty have a higher rate on wound healing and shorter time of wound healing. So we're talking about wounds here. It's important that everyone knows that even the distal embolizations, distal revascularization, are very important. You can see even the results of a meta-analysis done, which collects all the data about this revascularization, which just confirm the findings of the Rendezvous Registry. When we talk about this case, you can see how the foot was going worse and worse, but after the final revascularization, with, of course, appropriate wound care, the wound became smaller and smaller. It took 5 months to heal all this, but you can see how the wound now has completely disappeared, and the patient can continue to walk on this foot. And it's very important also to see the X-ray, where the osteomyelitic bone with this kind of very transparent and translucent margin now has become a proper healed bone with nice ossification at the level of the site of the amputation. So as I said, it's not just the people who revascularize the foot who are the protagonists of this healing. It's also about the team that is built around the revascularization strategy. And it's very important to have what we call in UK a multidisciplinary team meeting, where you can compare the images from, of course, the picture to the X-ray, and try to understand if there's any kind of infection, for example, which is one of the major problems of this patient, together with the ischemia. And there are different specialists: microbiologists, diabetologists, vascular surgeons, interventional radiologists, podiatrists, and all the people who are involved in the care of the patients, who attend this meeting and try to get the best results for our patients. And this is where level 3 comes. So all the centers were with advanced vascular skills, with advanced multidisciplinary team, and also can add something to the world data. So I call the world-class vascular center level 3 centers, where, for example, they can use new technology, which is slightly already established, like shockwave, which is a balloon which breaks the calcium in the artery by using the same principle of the lithotripsy for renal stones, and where new material can be, of course, be part of a trial, like absorbable stent, for example, or where even difficult and very new procedures can be done, like in this D2 trial, where the bypass from the proximal to the distal artery, which is occluded, is made through the vein. So I want to show you one of the cases of this sentence. Is a courtesy of Dr. Ferraresi, who was also the host of this session in this meeting. Case with no arteries going to the foot. This is called very microvascular disease. So when even the arteries going to the foot are completely absent, so it's called a desert foot. And post DVA, deep vein arterialization, which is a complex procedure which can be done by transforming the venous flow in arterial flow connecting artery with vein. You can see how the vein now is revascularized by the artery, and you can see how there's a complete different blush at the level of the forefoot here at this level, where the capillaries actually invert, so the venous capillary invert the flow to provide good let's say healthy blood to the tissue which are starving of oxygen. And you can see here how this foot, which had no chances even to go for a transmetatarsal amputation because of the complete absence of a direct flow to these tissues, then essentially went for a transmetatarsal amputation thanks to the intervention which was done, and now is happily walking with these appropriate foot shoes, of course. And then the last point is about everywhere in your region. So it's important to coordinate all these centers, and it's a fantastic example has been given by MARS, Manchester Amputation Reduction Strategy, coordinated by Mr. Nazir Ahmad, who's a surgeon in Manchester and a good friend of mine. And they managed to create a better pathway within the community where podiatrists on the territory can talk easily to the main vascular centers, and there's a complete two-way relationship and between hub and spoke hospitals, where that means that, you know, level 2 and level 3 centers can talk to level 1, and of course to try to be as much as possible spread on the territory, but also to have always a good feedback from people who are managing this critical limb ischemia more frequently, and even with long-term management of the patient. So essentially, even the patient who are more complex, who are managed in the hub, then they can be followed in the long term on the territory, with always a feedback to the main vascular center, level 2, level 3. And what about everywhere in the world then? You know, you can see here as a map with nice flags all around, but if you look at the publication which are talking about wider possibility for people to access this kind of vascular centers, you can see how the lower limb amputation data are a signal of an east to west health divide across Europe. And even more, you can see in this publication how this is more generalized into the world. If you look at the World Wealth Map 2018, you can see there are more countries which are colored with like reddish colors, like from the, of course, the pink to the mild orange, which are representing the countries with low income. And if you look at the map compared not only anymore to the geographical vastity of the different nations. Also, you can see here, if you compare it with the population which live in the country that we are talking about, you can see countries like India, which are as much bigger on this kind of scale compared to the geographical one. So many people who are poor or don't have access to services. And we all know how the cost of diabetic foot is an important thing, because it's very costly. And if you look at this paper, a very important paper from 2004, it was estimated like the foot care of single diabetic foot ulcer is estimated in $17,000, and it's almost a double for the amputation. But what does the amputation means in terms of cost? So which is the cost? The main cost is the care after the amputation. So people who have to go for physiotherapy, they need to have a new, of course, renewal of the place where they live, you know, and the long-term, of course, invalidity of people who can't work anymore, who need to stay in bed for long periods of time. If you cut all the service, then you will get to how the amputation ends up in very poor countries. So with the complete exclusion of the individual, even if it's young, from the society because of the impossibility to do any work. So I'm very proud to share with you this website of this association, Road to IR. These are people who are trying to get vascular services and also other services for IRs. But anyway, now here vascular services in Tanzania, where actually there's no vascular procedure done in all the country, and I'm mentioning how the sub-Saharan Africa is a very, very, very challenging, of course, scenario where no doctors are taking care of vascular patients. So, and it's very important for these countries to know that the patient education for preventing diabetic foot ulceration, apparently, especially in these kind of countries, alone is not effective in achieving clinical relevant reductions in ulcer amputation incidence. And it's very important to know also that what can be used is glycemic control, regular foot exams, which are very easy to be done and very easy to be done in the territory, and pain management. So if you reduce the amount of pain and neuropathy and glycemic control, then you will have better outcome for your patients who are less likely to develop critical limb ischemia and in particular tissue loss. So just to come to the end of my presentation, you always have to remember that we are treating not images, we're not treating feet, but we're treating lives, we're treating people. And I want to finish with this quote from Patch Adams, who said, you treat a disease, you win and you lose. But you treat a person, and I guarantee you, you will win, no matter what the outcome. In the meantime, I thank you for your attention.